Good evening, everyone, and welcome to today's webcast, Diet and Psoriasis. My name is Corinne Pettit, and I'll be your moderator for today's presentation. Before we get started, I'd like to go over a few items so that you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You've joined the presentation listening using your computer speaker system by default. This means that if you can hear music through your computer, you should be able to hear the presentation. If you'd prefer to join over the telephone, just select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit text questions to today's presenter by typing into the questions pane of the control panel. You may send in your questions at any time during the presentation, and we will collect these and address as many as possible at the end. Before I introduce today's speaker, I'd like to take a moment to tell those of you who may be new to the Foundation about who we are, our mission, and what we do. In 2014, the National Psoriasis Foundation developed a new strategic plan which drives everything we do as an organization. To achieve our mission, the following goals were identified. Number 1, accelerate discovery to cure psoriatic disease. Number 2, improve health outcomes. And number 3, achieve goals to help reach our mission, whether it's being involved with an event or becoming a volunteer. By attending today's program, you've already taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis to help manage your disease and find others who understand what it means to live with psoriatic disease. You can help accelerate our efforts towards a cure and greater understanding of psoriatic disease by participating in the MPF and Corona National Psoriasis Patient Registry, which is the largest independent observational registry of psoriasis patients in the U.S. The registry, which involves networks of dermatology clinics, collects and studies patient health information, allowing researchers to compare the safety and efficacy of psoriasis treatment, better understand conditions that are related to psoriasis, and explore the history of the disease. You can also share your experience with researchers about what it means to live with psoriasis and psoriatic arthritis by participating in Citizen Scientist. Answer questions and view your data along with thousands of other participants. Data is used to help researchers gain a better understanding of the disease. To learn more and participate, please visit the website listed on the screen after today's presentation. We continue to improve health outcomes through our Patient Navigation Center, the world's first personalized support center for people impacted by psoriatic disease. The Foundation's Patient Navigation Center is available to help you find physicians, treatment information, navigating insurance issues, access support through our one-to-one program, and more. Contact us at 1-800-723-9166 or visit psoriasis.org/navigation center. To achieve the Foundation's goals as mentioned, please support our mission through donations or by participating in a local Team MPF event near you. On behalf of National Psoriasis Foundation, I'd like to recognize our sponsor, Celgene. Without their support, this educational program would not be possible. Thank you for your support. Now I'd like to introduce today's speaker, Adam Ford. Mr. Ford is a research scholar, lead author, and fellow who works under dermatology expert April Armstrong at Keck School of Medicine of the University of Southern California in Los Angeles. Welcome, Adam.
Thank you, Corinne, and thank you to all the webinar attendees at home. I'm very excited to present the results of our research with you today, and I want to thank the National Psoriasis Foundation for this opportunity. I hope that you will find today's talk informative and that it may provide you with new insights as to how you can use diet to help improve your disease severity. I have nothing to disclose for today's talk. So during this webinar, I will be discussing the results of a systematic literature review that I conducted along with the medical board of the National Psoriasis Foundation on the effects of diet on psoriasis and psoriatic arthritis disease severity. The findings from this systematic review were used to create dietary recommendations for adult patients with psoriasis or psoriatic arthritis. These recommendations were recently published in the medical journal JAMA Dermatology. You can access this publication through the JAMA Dermatology website using the link provided to you through the webinar platform if you would like to review the article in its entirety, and that link will allow you to access the article for free. As many of you know, psoriasis is a chronic inflammatory skin disease that results in thick, scaly plaques that can be associated with itch, pain, and bleeding. Psoriasis is not uncommon and affects approximately 3.2% of adults in the United States. There is a large body of research demonstrating that psoriasis has a major impact on patients' quality of life. In addition to skin findings, psoriasis is associated with many comorbidities, including psoriatic arthritis, cardiometabolic disease, gastrointestinal disease, and mood disorders. Therefore, properly treating psoriasis can lead to improvements in patients' skin disease severity, their quality of life, and the impact of comorbidities such as psoriatic arthritis on their overall well-being. Various medical therapies exist for psoriatic diseases, including topical agents, phototherapy, oral medications, and biologics. These therapies have proven efficacy and have undergone rigorous safety evaluation via clinical trials and long-term registries. Regardless of patients' perspectives on established medical therapies, nearly all patients seek to understand how diet affects their psoriatic disease. In my experience in the clinic, this is one of the most frequent questions that patients have. Therefore, we decided to look into this with our study. Although psoriasis patients frequently ask their providers about how diet can influence their psoriasis, diet is rarely discussed during clinical visits. This is because most clinicians lack knowledge on how well dietary interventions work, because few articles existed that summarized literature on this topic. Our research study answers key questions on the role of dietary interventions in psoriatic diseases by providing evidence-based dietary recommendations that are accessible to clinicians and patients. In order to demonstrate the importance of evidence-based studies like ours, I want to start off with a quick thought experiment. Which do you think is more likely? Dying from shark attacks or dying from being hit by falling airplane parts? The answer, surprisingly, is that more people die from falling airplane parts than shark attacks. This demonstrates the concept of selection bias. When a shark attack occurs, the deaths are widely reported in the media, whereas deaths as a result of being hit by falling airplane parts are rarely reported in the media. As humans, our thoughts can be greatly influenced by what we are exposed to. Back to our topic, this could mean that psoriasis patients may be inclined to believe that certain diets are helpful only because they have been reported on in the popular media. Another important concept to keep in mind is availability bias. As humans, we are inclined to believe things that we can easily imagine. For example, when planning a military expedition, if the dangerous elements of the mission, such as explosions, are played up, the likelihood of success is perceived as low. We often overestimate the likelihood of vivid scenarios and underestimate the likelihood of difficult to imagine scenarios. Some patients may not believe that diet could be helpful for psoriasis just because it may be difficult to imagine how something you eat may affect your skin. Now imagine someone you know telling you, smoking is not unhealthy because my grandfather smoked 3 packs of cigarettes each day and lived to be 100 years old. This demonstrates how we are inclined to use an anecdote to support a bias we may have. The vividness and emotional impact of that example becomes more credible than actual statistical probability. One could also imagine a psoriasis patient saying, milk is bad for psoriasis patients because I stopped drinking milk and my psoriasis improved. One personal anecdote like this does not prove anything without proper statistical analysis. Because of our human nature to be influenced by so many types of biases, high-quality evidence is important in making any medical recommendations. The study on which our recommendations are based is a systematic review, which is one of the highest quality types of evidence available. I'm now going to briefly discuss the methods used for our research study. Specifically, I'll give an overview of how we conducted our systematic literature review and how we developed our dietary recommendations. To explore the current evidence relating to diet and psoriasis, we used literature identified by prior systematic reviews on this topic. We also performed additional systematic literature review by using a comprehensive search strategy to identify all research articles that have been published on this topic. Our review included studies from 3 different research databases, Medline, Embase, and the Cochrane Central Register of Controlled Trials. All research articles that were identified by our comprehensive search were screened to determine if they met our criteria for inclusion in our review. To be included in our review, studies must have been of observational or interventional study design. The study must have included participants with psoriasis or psoriatic arthritis. The study must have used a dietary intervention or examined food intake or dietary patterns. And finally, the outcome measured in the study must have included either psoriatic disease severity or patient-reported effects of diet on disease severity. Data from included studies were extracted into a spreadsheet for analysis. We also performed an assessment of the methodological quality of the included studies. The data from the studies identified in our systematic review were then used to develop recommendations for patients using established guidance to determine the strength of recommendations based on the level of supporting evidence. Level of evidence A refers to high-quality, patient-oriented evidence, which leads to a strong recommendation, or strength of recommendation 1. Level of evidence B refers to limited quality, patient-oriented evidence, which leads to a weak recommendation, or strength of recommendation 2A. And level of evidence C refers to low-quality evidence, which leads to a weak recommendation, or strength of recommendation 2B. The findings from the systematic review and the proposed recommendations were reviewed and approved by majority vote by the NPF Medical Board. Now I'm going to present the results of the systematic literature review. 55 studies met the inclusion criteria for our systematic review and form the basis for the dietary recommendations outlined in the remainder of this presentation. We identified relevant studies from a 64-year span of time dating back to 1954. These studies included a total of 77,557 unique participants, of which 4,534 have psoriasis. The majority of patients in the included studies were adults, and therefore these recommendations are for adults only and not for pediatric psoriasis patients. The first question we wanted to answer was whether gluten-free diets are helpful in psoriasis. So what exactly is gluten? Gluten is a general name for proteins found in wheat, rye, and barley. It's found in many foods that are derived from these ingredients, including bread, soups, pasta, cereals, sauces, salad dressing, malt beer, baked goods, and more. Celiac disease is characterized by an inflammatory response to dietary gluten in the small intestine. Antibodies in the blood indicating gluten sensitivity can be measured and can be used to screen patients for celiac disease, but definitive diagnosis of celiac disease is made by a biopsy of the small intestine. Psoriasis is associated with an increased risk of several autoimmune diseases, including a greater than 2-fold increased frequency of celiac disease. Patients with psoriasis also have an increased risk of positivity for the antibodies used as markers of gluten sensitivity. Furthermore, higher antibody levels have been associated with greater psoriasis severity. Some patients with psoriasis have markers of gluten sensitivity in their blood, but normal small intestinal biopsy results. Therefore, some patients with psoriasis seem to have gluten sensitivity in the absence of celiac disease. However, it's important to note that some controversy exists regarding the existence of gluten sensitivity in the absence of celiac disease. Our systematic review identified 3 studies on the effects of gluten-free diet on psoriasis. Based on these studies, we determined that gluten-free diet can be very helpful in patients with confirmed celiac disease. In these patients, a gluten-free diet not only ameliorates gastrointestinal symptoms, but also reduces psoriasis severity. In patients who test positive for serologic markers of gluten sensitivity, a gluten-free diet leads to significant improvements in both clinical psoriasis severity and skin biopsy findings. Among these patients, a gluten-free diet appears to be beneficial regardless of small intestinal biopsy results. And in the studies that we evaluated, a majority of the patients experienced worsening of their disease after resuming a regular diet. In contrast, studies show that a gluten-free diet is not helpful in psoriasis patients who test negative for serologic markers of gluten sensitivity. Here you can see the NPF Medical Board recommendation on gluten-free diet in psoriasis. Based on Level A evidence, we strongly recommend a gluten-free diet in adult psoriasis patients with confirmed celiac disease. Only in adult psoriasis patients who test positive for serologic markers of gluten sensitivity, we recommend a 3-month trial of a gluten-free diet as an adjunctive intervention to standard medical therapies for psoriasis. If patients do not improve after this 3-month trial, there's no reason to continue with the gluten-free diet. This is a weak recommendation as the evidence is more limited in this population. I would like to emphasize a very important point on this topic, which is that we do not recommend universal screening for markers of gluten sensitivity among adults with psoriatic diseases because these screening tests can frequently be falsely positive. Based on recommendations from the American College of Gastroenterology, patients who are candidates for screening include those with a first-degree relative with celiac disease or those with active gastrointestinal symptoms. The next question I will address is, what is the effect of dietary weight reduction in psoriasis? There's a well-established link between obesity and psoriasis. Excess body weight is associated with increased psoriasis incidence, higher psoriasis severity, and reduced response to psoriasis treatments. These associations may be mediated by the pro-inflammatory effects of body fat. Therefore, many of the comorbidities of psoriasis, including psoriatic arthritis and cardiometabolic disease, may be made worse in the setting of obesity. Our systematic review identified 11 studies on the effects of dietary weight reduction on psoriasis. Weight status as overweight or obese is defined using the body mass index, or BMI, which is calculated by taking a patient's weight in kilograms and dividing by their height in meters squared. In patients who are overweight or obese, a hypocaloric diet leads to significant improvements in psoriasis severity, dermatology quality of life, and weight loss compared to patients on a regular diet. A hypocaloric diet is one that delivers less energy per day than an individual's energy expenditure. In the included studies, hypocaloric diets ranged from having 800 to 1,400 calories per day. The duration of the beneficial dietary interventions in these studies ranged from 16 weeks to 6 months, but improvements in skin disease severity and quality of life can be prolonged and were shown to be maintained after 1 year. Dietary weight reduction is beneficial in conjunction with standard psoriasis treatments, including biologic therapy, oral systemic therapy, phototherapy, and topical therapy. It's important to note that dietary weight reduction alone may not be sufficient to maintain psoriasis remission, so patients should continue their regular medical therapy for psoriasis even after losing weight. Here you can see the MPF Medical Board recommendation on dietary weight reduction in psoriasis. Based on Level A evidence, we strongly recommend dietary weight reduction with a hypocaloric diet in overweight or obese adults with psoriasis. Dietary weight reduction should be used as an adjunctive intervention to standard medical therapies for psoriasis. And notably, weight reduction should always be recommended for any overweight or obese patient because it has beneficial effects on other health outcomes, including reduction of cardiometabolic and certain cancer risks. Limited data exist regarding other weight loss diets besides for hypocaloric diets in patients with psoriasis. Additional studies are needed to determine whether it is the type of diet or the weight reduction that reduces psoriasis severity, the amount of weight reduction needed for clinical response, how to implement dietary recommendations effectively, and the role of exercise in conjunction with dietary weight reduction. At this time, data are also lacking on the effects of dietary weight reduction in normal weight patients with psoriasis, or those with a BMI below 25. Next, I will attempt to answer the question of whether any dietary supplements are helpful in psoriasis. Our systematic review identified 38 studies on the use of dietary supplements in psoriasis patients. These studies show that dietary supplements are used by a significantly higher proportion of patients with psoriasis than those without psoriasis. This may be because many patients with psoriasis believe that supplementation can improve their disease severity. Patients surveyed most frequently report improvement from supplementation with fish oil and vitamin D. It's important to note that patients should consult with a healthcare provider before taking any supplements because many supplements can have adverse effects or contraindications. Polyunsaturated fatty acids are a type of dietary fatty acids that include both omega-6 and omega-3 fatty acids. The omega-6 fatty acids, arachidonic acid and linoleic acid, are metabolized into leukotriene B4, which is an inflammatory mediator that is elevated in psoriatic plaques. In contrast, metabolites of omega-3 fatty acids, such as eicosapentaenoic acid and docosapentaenoic acid, oppose the pro-inflammatory effects of leukotriene B4. The typical Western diet has an omega-6 to omega-3 ratio approximately 10 times higher than that recommended by an international panel of experts. Notably, lower psoriasis incidence is seen in regions with a higher relative intake of omega-3 fatty acids in their diet. Oil derived from cold water fish is rich in omega-3 fatty acids. And for these reasons, it has been hypothesized that fish oil supplementation may be beneficial in psoriasis. Here you can see some examples of foods that are rich in omega-3 fatty acids and others that are rich in omega-6 fatty acids. You will notice that many of the items listed for omega-3 are cold water fish. Of the 38 included studies on dietary supplements, over half of them evaluated the use of fish oil supplementation. The studies evaluating the use of oral fish oil supplementation in psoriasis show conflicting results. Several studies found fish oil supplementation to be beneficial, but several studies also found fish oil supplementation to have no benefit. Accurately assessing study quality is paramount when trial results differ, so we looked specifically at double-blinded, randomized controlled trials on this topic, which are particularly helpful in minimizing bias. Among the 9 double-blinded, randomized controlled trials, oral supplementation with fish oil was shown to be ineffective in reducing psoriasis severity in 7 of 9 trials, with 449 patients enrolled in trials showing no benefit and only 48 patients enrolled in trials showing benefit. There were also 2 studies that looked at intravenous fish oil supplementation, which was shown to have beneficial effects in reducing psoriasis severity. Here you can see the MPF Medical Board recommendation on fish oil supplementation in psoriasis. After close examination of the evidence, we do not recommend oral fish oil supplementation for treatment of psoriasis in adults because oral fish oil supplementation was not effective at the examined doses and durations. Although there is some data to suggest that intravenous fish oil supplementation may have a beneficial effect in psoriasis, the evidence for this remains too limited for a recommendation to be made at this time. Next, we are going to discuss the role of vitamin D in psoriasis. While topical vitamin D is well established as an effective treatment option in psoriasis, the benefit of oral supplementation is less certain. Studies show that vitamin D deficiency is common in patients with psoriasis, and lower levels of vitamin D in the body are associated with higher psoriasis severity. Therefore, studies have attempted to determine if oral vitamin D supplementation can lead to improvement in psoriasis. Vitamin D can be given in different forms, including cholecalciferol, alpha-calcidol, and calcitriol. Our systematic review identified 10 studies on the use of vitamin D supplementation in psoriasis. However, many of these studies were of low methodological quality. Overall, high-quality evidence is lacking to support the use of vitamin D supplementation in psoriasis. The 2 controlled studies that were identified showed no benefit of vitamin D supplementation for improving skin disease severity in psoriasis over a period of 3 to 6 months. Furthermore, in individuals without a history of psoriasis, vitamin D intake appears to have no impact on the development of psoriasis. Here you can see the NPF Medical Board recommendation on vitamin D supplementation in psoriasis. We do not recommend oral vitamin D supplementation for the prevention or treatment of psoriasis in adults with normal vitamin D levels. Data are lacking regarding the effects of vitamin D supplementation on psoriasis severity in vitamin D deficient patients. The next dietary supplement we're going to discuss is selenium. Selenium is an essential nutrient that can affect the immune system. Notably, studies have shown that decreased selenium levels can be seen in patients with psoriasis, and low selenium concentrations may be associated with longer psoriasis disease duration. Based on these findings, researchers have wondered if selenium supplementation can help improve psoriasis disease severity. Based on the 4 available studies identified in the literature, selenium supplementation seems to have varying results in patients with different subtypes of psoriasis. Specifically, selenium supplementation provides no benefit in patients with plaque psoriasis, either used alone or in combination with conventional psoriasis therapies. In one small study evaluating inpatients with a rare severe form of psoriasis known as erythrodermic psoriasis, selenium supplementation seemed to be beneficial in conjunction with conventional therapy. Here you can see the MPF Medical Board recommendation on selenium supplementation in psoriasis. We do not recommend selenium supplementation for treatment of plaque psoriasis in adults. Furthermore, because the evidence is so limited, we cannot make a recommendation for the use of selenium supplementation for the treatment of erythrodermic psoriasis at this time. We identified 2 studies examining vitamin B12 supplementation in psoriasis. Based on these studies, vitamin B12 appears to be ineffective as a therapeutic intervention in psoriasis. When compared with patients treated with placebo, high-dose vitamin B12 administered intramuscularly was shown to be ineffective in improving psoriasis severity. Based on this data, the MPF Medical Board does not recommend vitamin B12 supplementation for treatment of psoriasis in adults. Our systematic review identified 1 study that evaluated supplementation with a combination of micronutrients in psoriasis patients. This would be something like a multivitamin with all of the elements listed here. This small study showed that psoriasis patients receiving supplementation with a combination of vitamins and minerals in conjunction with low-dose methotrexate had significantly greater improvement in psoriasis severity over 3 months compared with patients treated with low-dose methotrexate alone. However, because this was only 1 small study, the NPF Medical Board determined that a recommendation could not be made regarding combination micronutrient supplementation for psoriasis patients at this time. Many psoriasis patients wonder if there are specific foods, nutrients, or dietary patterns that are helpful or harmful in psoriasis. In fact, a large proportion of psoriasis patients report having tried a special diet for their psoriasis, and a majority of patients believe that their dietary regimen can improve psoriasis. Although multiple observational studies exist evaluating the dietary patterns of patients with psoriasis, data demonstrating a relationship with disease severity is limited. In general, the dietary patterns of patients with psoriasis appear to be different from those of patients without psoriasis. However, in order to understand the impact of these dietary patterns on disease outcomes, additional research studies are needed that examine the relationship of specific foods, nutrients, and dietary patterns with psoriatic disease severity. Our systematic review did identify 2 studies evaluating the relationship of dietary patterns with disease severity, which inform the recommendations seen here. First, 1 study suggests that adults with psoriasis may benefit from adherence to a Mediterranean diet. Therefore, patients may consider a trial of a Mediterranean diet, including the following dietary components: consuming extra virgin olive oil as the main culinary lipid, consuming at least 2 servings of vegetables daily, consuming at least 3 servings of fruits daily, consuming legumes at least 3 times weekly, consuming fish or seafood at least 3 times weekly, consuming tree nuts at least 3 times weekly, and consuming sauce made from tomatoes, onions, and garlic and olive oil at least 2 times weekly. Secondly, 1 study that we identified suggests that adults with psoriasis may benefit from specific nutrients in their diets. Therefore, patients may consider a trial of consuming more of the following: omega-3 polyunsaturated fatty acids, monounsaturated fatty acids, fiber, and complex carbohydrates. And they may try consuming less of the following: total calories, saturated fatty acids, total polyunsaturated fatty acids, omega-6 fatty acids, lower omega-6 to omega-3 ratio, and less simple carbohydrates. These are weak recommendations, and they are based on the lowest quality level of evidence. However, because there are minimal risks associated with the implementation of these dietary recommendations, and because they may provide potential benefits for patients' overall health, patients are encouraged to try to implement some of these changes into their daily eating habits. Additional research is needed in this area and will help determine if there is an optimal diet that psoriasis patients can adhere to in order to help them achieve their best possible disease outcomes. The final question we will address is whether any of these dietary interventions are useful for patients with psoriatic arthritis. Although all of the studies we found on gluten-free diet included patients with psoriatic arthritis, they did not assess psoriatic arthritis disease severity or report outcomes separately in these patients. Therefore, it remains unknown whether gluten-free diet can help improve psoriatic arthritis severity. Additional research will be helpful in answering this question. In patients who are overweight or obese, dietary weight reduction with a 6-month hypocaloric diet leads to significant improvements in psoriatic arthritis severity and weight loss compared to patients on a regular diet. Whereas oral vitamin D supplementation seems to be ineffective in improving skin disease severity in psoriasis, it may be beneficial in psoriatic arthritis. Specifically, studies show that vitamin D supplementation for 6 months leads to significant improvements in psoriatic arthritis disease severity. In one small study evaluating in patients with psoriatic arthritis, selenium supplementation seemed to be beneficial in conjunction with conventional therapy. There were several studies that examined the impact of fish oil supplementation on psoriatic arthritis, and based on these studies, we determined fish oil supplementation to be ineffective. Compared with control patients, patients supplementing with fish oil did not experience significantly greater improvement in arthritis disease severity. There are no data available on vitamin B12 or the combination micronutrient supplementation in psoriatic arthritis. At the time of our systematic review, there were also no data to support specific foods, nutrients, or dietary patterns in patients with psoriatic arthritis. In order to understand the impact of these factors on joint disease outcomes, additional research studies are needed. Here you can see the NPF Medical Board recommendations on dietary interventions in psoriatic arthritis. Overall, high-quality data are lacking in this area. In overweight or obese adults with psoriatic arthritis, we recommend dietary weight reduction with a hypocaloric diet as an adjunctive intervention to standard medical therapies for psoriatic arthritis. As before, we would like to emphasize that weight reduction is advantageous for all patients who are overweight or obese due to beneficial effects on many areas of patients' overall health. With regard to dietary supplements, we recommend a trial of oral vitamin D supplementation as an adjunctive intervention to standard medical therapies. If patients do not notice a benefit from this intervention, they need not continue it past the trial period. Patients should consult with their doctor before initiating supplementation due to the risk of contraindications and adverse effects from vitamin D supplementation. Although there is some data to suggest that selenium supplementation may be beneficial in psoriatic arthritis, the evidence remains too limited here to make a recommendation. And finally, the available evidence suggests that fish oil supplementation is not helpful for the treatment of psoriatic arthritis in adults, and we therefore do not recommend it. Now that we have reviewed the specific recommendations from this study, I want to leave you all with the main take-home points from this presentation. First, adults with psoriasis or psoriatic arthritis may be able to supplement their medical therapies with dietary interventions in order to further reduce their disease severity. Second, patients should remember that when dietary interventions are implemented, they should be used in conjunction with standard medical therapies for psoriatic diseases. Discontinuing medical therapies while being solely on dietary interventions may lead to worsening of psoriasis. Third, dietary interventions can be associated with adverse effects and contraindications. Therefore, patients should always consult with their healthcare provider prior to implementing these recommendations. Fourth, patients should know that these dietary recommendations may have impact beyond their skin and joints and may be beneficial for their general health. And finally, we know that many questions remain to be answered on the impact of diet on psoriasis and psoriatic arthritis disease severity. Additional research will help us to answer these questions in the future. And listed here are the references for the studies upon which this presentation and all of the recommendations were based. And these can also be found in the article at the link provided earlier in the talk. So with that, thank you very much for your attention and to today's webinar. And I'd like to thank the NPF Medical Board for allowing me to contribute to this project and the NPF for this opportunity to share our findings with all of you. So I hope you found this presentation to be enlightening and that you have new ideas of how you can use diet to help augment your medical therapies to achieve the best possible outcomes in your psoriatic disease. And I'd be happy to address any questions you may have at this time.
Great, thank you so much, Adam. I'm going to send out the link for those that joined late. There's the link to the article that was referenced in this presentation, and we'll go ahead and move right into our question and answers. So we had a couple questions in here wanting to know if there's been any research done on the effect of turmeric.
So we didn't find any studies specifically looking at turmeric, no.
All right, thank you. Next question here. What do you think must be researched more closely regarding diet and psoriatic disease based on your review?
So I think there's definitely a lot of areas where additional research will be very helpful. I think the area that is the most lacking at present is just the impact of individual foods and nutrients and different types of diets on disease severity. So additional research there will be very helpful. There are data where psoriasis patients were surveyed and asked what types of foods and diets they believe might make their psoriasis better or worse. But this is just based on patient reports, and there isn't any hard scientific evidence for the impact of these different things on psoriatic disease severity. And then additionally, there were several of the recommendations related to supplementation where we weren't actually able to make a recommendation at this time because there was some evidence suggesting they may be helpful, but the evidence was just very weak and very limited. So additional studies on those topics as well will be very helpful to allow us to make a recommendation in the future.
Great. And next question along the same line. Since the study uses 64 years of research, have you taken into consideration more modern or newer diet product info?
So we took into account all of the studies over that time period, and all were given sort of similar consideration and weight. We did do an analysis of the quality of the studies, so that involves taking a look at the methods of the individual studies and ensuring that the studies were done correctly. And so in cases where the study quality was not good, we wouldn't have considered as strongly the evidence from those studies. And at times it's the case that the very old studies maybe weren't done with the same quality that we conduct research today, but that just varied based on the individual studies. So I wouldn't say that there were any studies specifically looking at sort of new or cutting edge diets. And again, that the effects of just different types of diets, such as the paleo diet or South Beach diet or a vegan diet, that is the area where we really need more research to understand the effects of those different diets on psoriasis.
Great, thank you. Next question here. I have avoided all foods that are psoriatic dry.
I'm sorry, can you repeat the question, Corinne? I missed that one.
Yeah, I have avoided all foods that are psoriatic drivers, but I'm still not clear. What should I do next?
So this is an example of how of some of the things I mentioned where patients may believe that certain foods or diets can make their psoriasis worse. And there is plenty of information about these different types of foods and diets in the popular media, but we don't actually have data suggesting that certain foods are kind of psoriatic drivers and make psoriasis worse. So the most important thing that any patient can do is to have regular medical follow-up with their provider and to follow the recommendations for medical treatments for psoriasis, as even in cases where diet can be helpful, it's the medical therapies that have a greater impact on the overall disease severity. So and other things that you could try would be the recommendations that we covered in today's talk. So trying some of the foods outlined relating to a Mediterranean diet and trying to avoid or eat more of some of the specific nutrients that I discussed as well. And just kind of seeing if that could be helpful, and also knowing that those changes may be kind of just healthy for overall health as well. And then if any patient is overweight or obese, really focusing on weight loss and getting to a normal body weight is one of the biggest dietary changes that an individual can make.
Great. Next question here. Why would oral versus intravenous fish oil supplementation make a difference?
So that's an area we're not entirely sure about, and that's why we didn't actually make a recommendation on the intravenous fish oil, because it was just a very small study that suggested that that may be beneficial. One could think of different hypotheses as to why that may be. For example, maybe when you take a fish oil pill, maybe you're not getting the same sort of dose as you would get if it's given via IV. Sometimes certain things aren't absorbed very well in the stomach, and perhaps it could be that a higher dose was leading to the benefits seen in that study. But again, we are not recommending intravenous fish oil for psoriasis patients because the research just isn't there yet to really confirm that that's going to be beneficial for patients.
Thank you. Next question. Since vitamin D supplementation was discussed in the presentation, both oral and topical, would vitamin D therapy via sunlight or dermatologist office UVB treatment be appropriate?
So topical vitamin D is actually not, it's not the vitamin D created by the sun or by phototherapy that we're referring to. It's actually something called calcipotriene, and that would be actual topical medication. So something like an ointment or a cream or maybe a foam for the hair that is vitamin D applied directly to the skin. And so there is it's been well established that that can be an effective treatment option in psoriasis. Oftentimes providers will combine that with topical steroids to get some additional benefit from topical therapy.
Great. Next question here. Can you speak a little more about patients who are under 25 BMI and if a lower caloric diet might help their symptoms?
So that is another area that additional research will help us figure out if that is beneficial. So all of the studies we identified only enrolled patients if they were classified as overweight or obese using the BMI. So all of the data we have in this area is exclusively on patients that are overweight and obese. So we can't really make a recommendation on that because there's just no data showing what the effects of that would be. Patients may choose to sort of try that diet, and if they want to lose a little bit more weight, even if they're not overweight or obese, as long as an individual is eating a healthy diet and doing so in communication with their provider, with their physician, then that's something that is not going to be harmful as long as they're maintaining adequate nutrition and intake of essential nutrients and not falling to a low body weight. We don't want to suggest that anyone should become underweight by adhering to a diet like this.
Thank you. We've had several questions about nightshades, research around nightshades, and also if you could speak to the fact that nightshades are a large part of the Mediterranean diet.
Yeah, so again, this is an area where there are several articles published in the medical literature that report that various foods and diets may be helpful or harmful. And with these studies, using surveys of psoriasis patients and their perceptions of how diet impacts their disease. So in other words, the data in these studies is based on individual patients' personal experiences. And other than the things I mentioned in the talk, there's currently no evidence demonstrating that specific foods or diets make psoriasis better or worse. So although psoriasis patients may believe that nightshades impact their psoriatic disease severity, we don't have solid scientific evidence that this is the case. And so we're kind of unable to comment on the impact that they have. So it is true that many of these sort of vegetables and would be included in a standard Mediterranean diet. If patients feel that there are specific foods that are making their psoriasis worse, then by all means they can continue to avoid those foods. But we're unable to kind of comment on the effect of nightshades in general for psoriasis patients.
All right, thank you so much. Well, that's all the time we have for questions today. If you do have any other questions, please contact our Patient Navigation Center, and they are available by phone, email, live chat, or Skype. And once you leave today's webinar, you'll receive a survey on today's presentation, and we'd appreciate if you can complete that and provide your feedback. I want to say thank you again to our sponsor, Celgene. And finally, I want to mention the recording of tonight's webcast will be available shortly on our website at archive@psoriasis.org/webcast. Thank you, everyone, for joining us, and we hope you have a lovely rest of your day.